Hello everyone. Welcome to this educational session for healthcare professionals. Today, we will discuss hyperkalemia, one of the most important electrolyte abnormalities encountered in emergency departments and intensive care units. Hyperkalemia can rapidly progress from an asymptomatic laboratory abnormality to a life-threatening arrhythmia and cardiac arrest. Prompt recognition, ECG interpretation, and timely management are therefore essential. By the end of this video, you should be able to define hyperkalemia, understand its causes and pathophysiology, recognize clinical and ECG manifestations, and follow a systematic approach to management. Hyperkalemia is generally defined as mild, 5.5 to 5.9 millimoles per liter, moderate, 6 to 6.4 millimoles per liter, and severe, greater than or equal to 6.5 millimoles per liter. However, remember that the severity of hyperkalemia depends not only on the potassium value but also on the rate of rise, presence of ECG changes, underlying cardiac disease, and renal function. A potassium level of 6 millimoles per liter developing within 1 hour may be far more dangerous than a chronic level of 7 millimoles per liter. Approximately 98% of total body potassium is intracellular, with only about 2% present in the extracellular fluid. This steep gradient is maintained by the sodium-potassium ATPase pump and is essential for neuromuscular transmission, skeletal muscle contraction, and cardiac conduction. Hyperkalemia occurs due to one or more of three mechanisms. Number 1, excess potassium intake usually contributes only when renal excretion is impaired. Number 2, reduced renal excretion. This is most common mechanism. Examples include acute kidney injury, chronic kidney disease, hypoaldosteronism, and adrenal insufficiency. Number 3, shift of potassium from intracellular to extracellular space. Examples include metabolic acidosis, diabetic ketoacidosis, insulin deficiency, tissue breakdown, tumor lysis syndrome, and rhabdomyolysis. A practical way to remember causes is the 5D. Number 1. Decreased renal excretion. Examples: AKI, CKD, and adrenal insufficiency. Number 2. Drugs. ACE inhibitors, ARBs, potassium-sparing diuretics, NSAIDs, trimethoprim, calcineurin inhibitors, beta blockers, and heparin. Number 3 is distribution abnormalities. Movement out of cells, acidosis, DKA, hyperosmolar states, and tissue destruction. Number 4. Dietary excess, usually significant only in renal failure. Number 5 is deceptive hyperkalemia or pseudohyperkalemia, caused by hemolyzed samples, marked thrombocytosis, extreme leukocytosis, and prolonged tourniquet use. Always repeat potassium measurement if clinical findings do not match laboratory results. Many patients remain asymptomatic. Symptoms may include generalized weakness, fatigue, paresthesia, ascending paralysis, flaccid weakness, and respiratory muscle involvement in severe cases. The most feared complication is cardiac arrhythmia. Classical ECG progression include tall, narrow, peaked T waves, Shorten QT interval in early hyperkalemia. Moderate hyperkalemia includes PR prolongation and flattened or absent P waves. Severe hyperkalemia. Widened QRS complexes, sine wave appearance, ventricular fibrillation, pulseless electrical activity, and asystole. However, remember an important teaching point. ECG findings correlate poorly with serum potassium levels. Patients with severe hyperkalemia may have minimal ECG changes, while others develop dangerous arrhythmias at lower potassium concentrations. Management can be simplified into 3 objectives. Step 1. Stabilize the cardiac membrane. Indications: ECG changes, potassium usually above 6.5 millimoles per liter, or life-threatening arrhythmias. Administer calcium gluconate 10%, 10 milliliters intravenously over 2 to 5 minutes. Calcium chloride 10%, 10 milliliters intravenously. Remember, calcium does not lower serum potassium. It stabilizes myocardial cell membranes and reduces the risk of fatal arrhythmias. Its effect begins within minutes and lasts approximately 30 to 60 minutes. Step 2. Shift potassium into cells. Insulin with glucose. Regular insulin 10 units intravenous followed by dextrose administration. Onset: approximately 15 to 30 minutes. This is one of the most effective therapies. Beta-2 agonists. Nebulized salbutamol can further lower potassium and acts synergistically with insulin. Sodium bicarbonate may be considered when significant metabolic acidosis is present, although its potassium-lowering effect is less predictable. Step 3. Remove potassium from the body. Diuretics. Useful if renal function and urine output are adequate. Potassium binders, such as sodium zirconium cyclosilicate or patiramer in selected patients. Hemodialysis. The definitive therapy for severe hyperkalemia in renal failure, refractory hyperkalemia, or ongoing tissue breakdown. Always identify and treat the underlying cause simultaneously. Before ending, remember these 5 take-home messages. Hyperkalemia can cause sudden cardiac death. Always exclude pseudohyperkalemia. ECG changes do not reliably predict severity. Treatment follows 3 steps: protect the heart, shift potassium intracellularly, and remove potassium from the body. Hemodialysis remains the definitive therapy for refractory or severe hyperkalemia. Thank you for watching. If you found this video useful, please like, share, and subscribe for more evidence-based critical care content for clinicians.